So the venous disease that involving the legs carries a significant morbidity across our country, but fairly minimal mortality. So it's usually involves an age group that's slightly older. Therefore, they tend to stay in primary care rather than come to secondary care with that problem. The two areas to think about are those patients who have significant varicose veins and those patients who have complications of the varicose veins. In general, we have a younger age group who are concerned about the quality of life issues: aching, itching, throbbing, unsightliness or cosmetic changes can cause a lot of distress but aren't medically important. The medically important ones will tend to be disorders like bleeds. So little ladies, often little old ladies, will knock their delicate skin and it will bleed quite extensively. Superficial thrombophlebitis, inflammation and a clot in the vein, and venous leg ulcers or progression towards venous leg ulcers. Again, not high mortality, but significant morbidity to the individual. So I think if we look at the medical significant disorders from venous disease, considering phlebitis, superficial thrombophlebitis, a clot within the superficial vein, where initially the leg is hot, red, tender, with a tender, firm cord, which after a week or two becomes a firm, mauve, non-tender, non-hot cord. The treatment for that has to take into account two facts. First of all, if the superficial thrombophlebitis is not related to the varicose veins or a knock of the varicose veins, which can be quite trivial, it could be related to something that's making the blood more clotty, more hypercoagulable, such as an ovarian tumour or an abdominal carcinoma from the pancreas, and therefore some form of imaging is also needed, possibly a CT, but that depends on the individual patient. The second thing to think about is that if there's a superficial thrombophlebitis, a clot in the superficial vein, there's a risk of having an associated deep vein thrombosis, especially if the phlebitis is extensive. And that means there's been a slight shift in the change of management. Not only the management of the pain with analgesics, the management of using Hiridone cream or stockings, but also the idea of getting imaging of the abdomen to exclude a carcinoma, imaging of the leg in the form of a duplex scan to exclude a deep vein thrombosis, but also to consider using low molecular weight heparin to treat the phlebitis, anything up to 6 weeks, almost at treatment dose, and secondly to consider removing any residual varicose veins once all the phlebitis has settled down.